Unmuted now. Okay, thank you so much. I'm a pediatrician by training, and together with my colleague, we founded Diabetes in 2006. It is founded in the Netherlands. We currently have one location in Rotterdam, a big city where we started, and you now have 5 other locations across the country, covering, let's say, a nationwide possibility that patients can be reached of our center. As you see from the picture, we don't want to look at like a hospital. It's colorful, it feels more home, and we have a team which works there. There is no other specialty on the floor, so it's really focused on type 1 diabetes only. Just like the Olympics, we only do type 1 diabetes, and the staff there only does do type 1 diabetes. So if you work on that 5 days a week, every week in the year, you get better. Just like the Olympics, take that as an example. And most of the time, hospitals do have staff which do this in a Monday afternoon in a fortnight. So it's less experience. In the upper left panel, you see the boxes of the new boxes of the consultations where we do the remote consultations with the patients at home, and especially before COVID, and especially now during COVID, most of the consultations will reach out from home. And then we schedule the visits where there is a need to show up for physical exam and laboratory results. On the next slide, you see it all turns around IT. In the upper panel, you see the racing car depicting, let's say, our team, free of hierarchy. Everyone is important. Everyone needs to share their best practice. With IT, we take up all the data from the patients continuously, from the devices at home, and we reflect it back to the patients so they can improve. We can see the data, and in the middle picture, you see the improvement. You see the different balls which represent the outcome of different clinics in the Netherlands. And the more the right you go and the more to the lower side, the better your performance is. And currently the orange ball is representing diabetes. And it has sucked up, let's say, 80% of our patients do come from other clinics for further improvement and take the benefits of the technology. In the lower left panel, you see the ratios, the amount of physicians, patients we can treat by one physician and by one nurse. That's half of the ratio in normal hospitals. So our staff can handle twice the amount of patients and reaching a better outcome. And that is reflected in cost. And then we bundle, since we are one entity, all the cost we spend is on the diabetes care. So we exactly have a handle on what it costs and also try to reduce the future cost. In the next slide, you see how we do the measurements in the different therapy pathways in MDI, pump patients, and sensor-augmented pump patients. You see the color codes, and actually every line represents a physician or a nurse. And you see some in the upper panel more to the red, in the lower to the green, they do better. So this is the distribution in the different care providers. The more experienced you are, the more you get in the green region. And the more the other people can learn from you in order to keep up with this achievement. So this is not a performance per hospital. This is a performance per healthcare provider. And we try to identify what are the denominators to get to the better. And we gradually, every year, it's getting better. In the next slide, you see that we have these bundle costs, and now we make a projection to the insurance company to actually say, if we deliver better care now, can we reduce the future cost? And in the right panel, you see that the biggest insurance company, Silver Cross in the Netherlands, against age, from their database, the complication cost, and the size of the circle is the size of the cost. And it's a huge amount of cost. And if we can reduce now, like a reverse pension fund, invest now, we can reduce the future cost, and we can calculate how much that will be. And this is the kind of handle we do, that if those patients get treated with us and we have the contract with insurance companies, that we can make them better, the patients better, and also reduce the future costs. So also for the payers, there is in the long run a benefit. Briefly, this is what we do. There is much more to explain, but briefly, this is better outcome and reducing costs.
Thank you very much, Hank. If someone will be in need to get in touch with you through organizers, they're definitely going to happen. The quick question is, you in fact, we are speaking about how to motivate different stakeholders in the field. Costs argument works well for insurance, for instance. What is the argument that works the best to get physicians and nurses on the board? How you can sell this idea in a good, honest way to nurses and physicians?
Many of the nurses and physicians want to be part of a winning team. What you sometimes see, that some will not join because then they cannot fly at this high level. And so it's really an invitation for those who want to focus, who want to be creative, and achieve something for the long run. And as you can see on the ratios, we don't need all the people, but it is of special interest. You have those physicians who are focused on surgery, and you have the ones who are on the other processes like we do, and motivating patients, be close with patients, and also enjoy that they appreciate that highly, those patients, and patients bring in other patients. That is how we grow.
Thank you very much, Diabetes Senior International Medical Director, Mr. Hank Wiese. Thank you very much for your time. And we are going to the next pitch of ours, which will be here in our house, we can say so, in our summit house. Emil Syndikov, Chief Technology Officer, also will be the moderator of our panel session later. Longenesis, Accelerating Biomedical Research. The floor is yours.
Thank you. So good afternoon, everyone. My name is Emil Syndikov. I'm a Chief Technology Officer at Longenesis. So our team being a combination of computer scientists, clinical specialists, and business strategists, we have asked ourselves a question: how can we accelerate research and empower data-driven decision-making in healthcare with using the digital technologies? Yeah. So the challenge lays within data, which is siloed, and we have heard this multiple times, and we'll be hearing this multiple times today, which is siloed and fragmented across different institutions, often unstructured and not being utilized. Inbound with data privacy and security, as well as lack of engagement challenges, it brings us to the point where collaboration happens in very slow cycles. We at Longenesis bring an end-to-end intuitive toolkit to connect stakeholders for real-time data discovery needed for research or healthcare decision-making and patient-centric engagement, and providing each patient with tools for having control over the data use and being the privacy and ethics by design at heart. So a little bit more about our solutions and the cases. So while the state of the art pushes organization for centralization and so-called ingestion of data in one place, we created a platform called Curator for helping to discover data needed for research, to connect hospitals, patient advocacy groups, both academic and industrial partners all together, and that follows a data stays local principle, meaning that data stays for the treatment needs without even leaving the clinic, helping to avoid any privacy concerns, and actually enabling federated learning we heard today before. How we do that? We operate with data about data, which is called metadata, which is anonymized and gives an ability to have pointers to the exact investigators, patient groups, registries, labs, biobanks, etc. Inbound with dynamic consent management module called Themis. As an example, we help the government of UAE to create a first of its kind nationwide genome initiative, providing each participant with a tool to be proactively engaged in research and healthcare initiatives, while controlling and providing this control of the use of data with the device we all have in our pockets. Our solution called Engage serves as a digital bridge connecting investigators, researchers, clinicians with patients and also broader population to generate real-world data and act upon it. So a little bit about traction highlights. And then moving toward the case studies. So being data type agnostic, we started operating within 6+ disease domains and empowering more than 200,000 patients from worldwide, like working from Latvia. Our solution is recognized by multiple awards, such as an example, Finnish government Fair Data Prize, marking our solution as a prime example for secondary health data use. So a couple of examples here. So we've joined forces with patient advocacy groups and KOLs and endocrinology and a company called Medtronic to actually engage hand in hand and engage patients in real-world data generation for quality of life to understand the insights better, to form better treatment strategies. Our project with researchers from Boston University, researchers from Israel, clinicians and researchers from Latvia with a platform called Iesaistos.lv helped to create a data-driven decision-making and personalization of scientific communication in relation to COVID vaccination and based on the risk of disease prevalence in a chronic condition. We also operate in social and public health space. So this is a prime example happening in Latvia, where we create a platform called screenings.lv to raise the preventative culture in relation to breast cancer. This platform connects more than 8.5 thousand female participants in Latvia, and each of them receives the personalized report as a call to action to start conversation with their clinical practitioner, with the gynecologist or GP, to form this dialogue altogether about this disease and prevention mechanism. But inbound with dynamic consent management, we bring a solution to the researchers and public health institutions actually to work and provide decision-making based on data metrics and connect them with groups of participants to work hand in hand in scientific initiatives or with the public health/screening initiatives. Yeah, with this in mind, having 20 seconds left, I would like to thank our team, so the best of its class Latvia-based team to work on these global initiatives in more than 20 countries, and for sure our advisory board. As a call to action, I would like to encourage all of the stakeholders being present today to not be afraid, work towards data-driven decision-making and utilize data for the clinical processes, but actually not forget about patient centricity and giving these tools for being proactive to the patients themselves. Thank you so much.
Thank you very much, Emil. Very quick question, because in the panel discussions you're going to dive into everything, but it's mentioned that ethics should be by design in the ethical consumptions and assumptions. The question is, very quickly, what is the biggest threat? What can go wrong in a couple of sentences? Why the ethics should be very important?
I think that, this is the core of our mindset process. So basically, patients are being engaged. If we're speaking about clinical research, mainly patients are being engaged in a passive manner. When I speak about that, I mentioned that, the use case when the clinical investigator comes, he asks some questions. This data will be used for the sake of the research, but myself as an individual also participate in several clinical studies beforehand. I'm not getting any value. At least the understanding of scientific insights, what happened with that, whether I contributed to something that will help myself or even the closed ones. And I think with this in mind, to change the mindset, and one of the tools is dynamic consent management as an example, because we see the higher engagement rates, which helps clinical investigators, also both academic and industrial partners, but from another hand, empowers individuals. So you get the value out of the process, so you have the motivation to participate. So win-win situation there.
Wonderful. We are really looking forward for your panel discussion. Thank you very much. Thank you. And the next pitch, we are switching over. We'll speak Smatomica is a Latvia-based biotech company focused on the development of comprehensive artificial intelligence-based solutions to translate scientific data specifically relevant for each individual patient into clinically usable products for the benefits of both the doctor and the patient. So artificial intelligence comes into the game. Smatomica data analysis for personalized medicine. Mr. Renāts Lokomets, Smatomica representative. Please, the floor is yours. You are on the Zoom.
Good day. My name is Renāts Lokomets. Do you see my presentation? Smatomica is Latvian, European-based company what is dealing with, I can see the presentation, okay. So Smatomica is a Latvian-based company what is starting this process combining different expertise worldwide. Smatomica founders came from a different direction, from Israel, from Russia, from United States, and combined their expertise to start a company here in Latvia, because Latvia is, we think, what is a very good place to start a new biotech, health tech, medtech project. Currently, Smatomica is developing comprehensive methodology for AI-based clinical data management platform in personal medicine. With the methodology is allowed to unify the approach to work with the patient with established diagnoses who do not benefit from a conventional treatment. Can you use next slide, please? Yeah. Can you go to the next slide? Yeah, no. Come back. So Smatomica already had this expertise already works for more than 7 years, and the methodology what is used, Smatomica used already help to dozens of patients to provide very effective treatment worldwide. Smatomica tries to cooperate with all different kinds of scientific investigators worldwide to combine all expertise and to make the tool the most, to create a very good and effective tool. Can I go to the next slide, please? So the Smatomica tool is a clinical genetic interpretation platform. So as we all know, there's a lot of data what is already collected in the world. As data related to oncology and in general disease. So our tools automatically extract information from all the founded scientific publication. It's around 3 million of articles that are already proceed from different sources, PubMed, evidence-based databases, etc. And using the AI combined, create very advanced technological advanced report what can give to the doctors and to the scientific teams more understanding how and what disease can be treated. So from the beginning, with Smatomica is taking the genetic data of each of the personalized data of a patient, taking the genetic code and then combine turning to make the genetic report what is can help to the doctors and to treat the patient in the best way. This report is very user friendly. It's integrate unique AI treatment selection and where genetic data is used. Currently, we already cooperate with Latvian Pediatric Cancer Initiative, where Smatomica provides services genetic data interpretation for children with oncology in Latvia. Can I go to the next slide, please? Additional Smatomica development of a tool what is not only related to oncology, but also providing the tool what can be used for the investigators and scientific teams. It's an analytic solution what can analyze by using artificial intelligence analyze a lot of data and provide a list of articles and list of well summarized information about disease, about the special cases. And already a couple of universities are using these tools, and I think it's make a great economy from the point of view of time and efforts for finding additional information and to do it in a without mode. Next slide, please. If to talk about the call to actions, it's important to mention that Latvia during the last couple of years, the progress what is happening here in the health tech and medtech is very good, and we see what more and more clinician organization, universities, and doctors are thinking about using additional and alternative data sources to provide personalized or patient-centric treatment for patients. What is we think what is needed and what is now it's under development is molecular tumor board. What is very important to have in Latvia, which it will allow experts work collaboratively of difficult cancer patients. It's also important to have a legal possibility for a doctor to apply for permutation for with molecular tumor board. If this issue will be solved, so the Latvian patient will be treated in most effective way. It's according to our understanding and according to the practice what Smatomica already sees in worldwide. So it's all from my side. Thank you very much.
Thank you, Renats, very much. And you already mentioned what is the need for further development. Maybe you can mention also what is the biggest challenge for your technology to be scaled up in Latvia, especially. What's your headache at the particular moment?
Let's be defined in this way. So it's a headache what we see. It's not only a headache in Latvia, but overall, science where doctors is graduating from the universities 20, 30 years ago, and their education were based on the traditional standards and traditional approaches. For the doctors, when all new technologies and genetics, it is something very new, and to understand it and to be closer to it, it will be the way how to educate doctors and specific like doctors who are treating their patients and to bring them new technologies and new standards of treatment of patients. It's happening worldwide. It's not only it's not only Latvian case. So we know what in 20 years the genetics will be used more and more, but currently this use is limited. It's a current situation.
Okay, thank you very much, and definitely in our panel discussions considering the education and agility of personnel to use the technology also will be on the table, this question. Renats Lokomets, Smatomica representative, thank you very much for your time. The next pitch we are moving on, we'll speak on importance of availability of patients' data for secondary use, how we make conclusions on that based already on the research we have, use of patient secondary data for value-based health care. Lilian Tsivian, Professor, Faculty of Medicine, University of Latvia. Good morning, and how are you?
Good morning. I hope you can see me.
Yes, we can.
At least. Okay, so I'll speak about the use of patient secondary data for value-based healthcare based on our new study on survival of non-small cell lung cancer patients in Latvia. And when we started this study, we knew already that the lung cancer is the fourth cause of death in Latvia. And although the value-based healthcare first was proposed in 2010, it's still not available in our country. So our aim in this study was to compare survival of lung cancer patients in Latvia and in Israel, where this strategy is already implemented, with the attempt to conclude on importance and availability of this strategy also in Latvia. We decided to investigate three major domains of lung cancer patients that were treatment conditions like time to diagnosis, time from diagnosis to treatment, time from treatment and number of courses needed, and so on. Patient-related conditions, and the main outcome, as I mentioned, will be the overall survival of patients, but we will see also the time to complication to rehospitalization, to progression, and so on. And additionally, we will perform the cost analysis of standard care for non-small cell lung cancer patients, which is already available in Latvia, and to make a prognostic model of cost in the case of implementation of value-based healthcare. The first part of the study is the retrospective analysis of data of patients that were hospitalized between 2016 and 2018 in Riga East University Hospital, taken from the database of this hospital information. And we included in this study 400 patients, 100 for each stage of the lung cancer. And already from the beginning of the study, just by identifying the categories of data that we would like to analyze, like socio-demographic, risk factor, clinical, diagnostical, treatment, mortality, and cost data, we saw that there are several authorities which hold this data, which makes the secondary use of them quite difficult. So we saw here two major challenges. The first of them is the lack of appropriate information or non-consistent information between several databases. For example, family history of cancer, or especially smoking status and occupational status of lung cancer patients, which is very important information for especially lung cancer patients, is completely lost in the family histories and every of registries. Genetical information or mutational status is available only for EGF receptor, and it was only in 3% of our participants. For 11 genetical mutations, we don't have any information in databases. And we have also the problematic assessment for even available data, like information is divided between different authorities, so hospital, ambulatory, and the Center of Disease Control, National Health Service. Each one of them holds a part of information about participants, and only a part of the information is in physicians' electronic databases. But information on most of patients' data is in handwritten medical histories, and it makes the secondary use of it completely impossible. So first, even in this retrospective part of the study, we see the urgent need for complete electronic database, including all data and costs for patients for implementation of value-based healthcare strategy. And we are planning also now the prospective study, which will include the changes in strategy in one particular hospital to compare with the previous strategy. And certainly we are looking for funding to start this study. Thank you.
Thank you. Thank you. Thank you very much. As always, it is the question, of course, considering scientific research. What could be your recommendation for further scientific researchers in this field? What is the most important next step to do to continue?
We plan our research. I can speak only about our one. We would like to change the strategy in one hospital and to compare the survival of patients after implementation of value-based healthcare with the survival of patients before we implemented it. Certainly more research always is needed to prove the value of some new strategies, but I think there's plenty of information in the world already, so we can only follow this information.
Okay, thank you. Thank you very much. And wishing luck with the further research. We are switching over to the next pitch today. Data collaborative project. Data which are saving people's lives, and the data which are usable to improve decision-making, especially in prevention, early detection and management of gastric cancer and its malignant lesions by scalable data, agnostic data driven, and other ways that technology as offers. It's a pleasure of mine to introduce here on the stage, from my personal perspective, a good friend of mine already, Professor Marcis Leja, Faculty of Medicine, University of Latvia. Please, the floor is yours.
Good morning. Thanks for this kind invitation, and really happy to present the Data Collaborative here. And the subtitle of this collaborative is aiming really for gastric cancer prevention, including the strategy with gastric precancerous lesions. And first of all, what Data Collaborative is. Actually, Healthcare Data Collaborative is a new format of collaboration between the clinical partners, between industries, between everybody that should be involved, definitely including also patients and the population in general, to collect the data from multiple sources, to analyze them collectively. And in this case, this data collaborative has been actually supported from the Microsoft company, but this is expected to involve either major clinical partners in Latvia or in Europe, or even maybe outside Europe, as well as industry partners and developers. And in this case, we are speaking on gastric cancer and precancerous lesions. Why? Actually, most of the gastric cancer cases, around 90%, is caused by bacteria, by Helicobacter. But there are multiple other factors committing, including lifestyle factors, including the genetics. Hereditary cancer is very rare, but genetics is also contributing to the development of cancer. But most importantly, that is most important really to identify those that are at increased risk and to monitor them closely throughout the course of the potential disease. And large data could help with this. First of all, we do not have currently a valid method to screen for gastric cancer in general population, and that is very high on the European agenda currently. Some of the tests, biomarkers, including volatile markers in the breath, are really very interesting, and not only for gastric cancer. Then I touched already the host genetics, that it's important also outside the hereditary cancer. But most importantly, probably, and the area that is rapidly developing is AI-based approaches, either in endoscopy or in pathology, and I will give examples to this. And then if putting all those data together, the complex analysis really with all the factors to be included with the biomarkers, simple and more complicated biomarker tests, autoimmunity, Helicobacter and its subtypes, that might really provide an important solution to the current state of art. And that is just to illustrate artificial intelligence in endoscopy. Actually, it is already there, but not for the upper gastrointestinal pathology, not for the stomach. And that is one part to be included in this data collaborative. The other part is artificial intelligence in pathology, a very rapidly emerging field. Not the pathologist anymore evaluating the slides, of course we cannot live without the pathologist, but machine really trying to identify the lesions. Once more, very, very interesting field. And just to illustrate the marker approach, and those are the example of volatile markers that are read by sensors. You can see multiple signals there, and probably it would be difficult for a human to identify or to have conclusion out of these curves. The machine can do this. So for this reason, we have created this consortium to evaluate, to put together those data, and actually to include multiple data and to include multiple stakeholders, as mentioned already before, including clinics, citizens, and decision makers. This caracol consortium has been set up by the leading universities in Europe in the field, including from Portugal, Slovenia, Netherlands, Rotterdam University Medical Center, each really being the expert institution in its own field. And finally, this has been also suggested as to GAIX platform for European health data space as a specific project, and we are currently expecting hopefully a positive response to get the project included there. Thank you.
Thank you very much, Professor. The question, of course, is about when artificial intelligence or machine is working with the data should be in a good quality. Can you comment on the issues with the data quality in the time when you are gathering them, especially in your field?
Thanks. That is absolutely a very critical issue. And first of all, the standardization of the data. As we heard in the previous presentation, standardization of the metadata is really a very important aspect. Capturing of the new data absolutely also is requiring certain technology solutions. Without this, they cannot really be analyzed collectively. That's absolutely true.
You also showed the slide with the ecosystem, and the ecosystem is what we are speaking about for anything to work in the modern digital healthcare. What would be your, I don't know, the first most important step to do that ecosystem starts to run smoothly?
I think, first of all, we do have good resources here in Latvia, either for AI development or from a clinical part, laboratory medicine as well. So that could serve as a small ecosystem. But then, of course, we need an important partners in data, building up the data ecosystem, and whether those are among the potential institutions in Latvia or abroad. As for this project, we are collaborating with Microsoft. I think that could give the solution, but really to have this could be really the first steps for setting up the ecosystem. However, really to run and to have conclusions, we need to have a much broader ecosystem involving really many partners in many countries, maybe even not only limited to EU countries.
Wonderful. Thank you very much for your answers, Professor. Professor Martis Leja was delivering his message, and we are going to our next pitch. Molecular tumor board implementation, the introduction of next-generation sequencing in a clinical practice opens new horizons indeed for precision in oncology. And our next speaker, it's always a pleasure to introduce representatives from Children's Clinical University Hospital in Latvia, which is really a headliner and also in the first lines of innovations. Mr. Valds Ābols, the floor is yours. Good morning.
Hello, thanks a lot for the introduction. So, dear friends and colleagues, on behalf of the Children's University Hospital, I have agreed to share with you a short example of a joint initiative that, in my opinion, vividly illustrates how generation of new data and the ability to interpret data may lead to better health outcomes. Although this is still work in progress, I hope it will provide some insight on a direction where we are heading. I'm not an oncologist, nor the bioinformatician or data scientist. I'm looking solely from a hospital manager perspective, caring for better health outcomes for kids and obviously quality of life for the whole family. By said that, every year, over 50 children in Latvia are diagnosed with a cancer. And many cancers are aggressive and hard to treat, with a high risk of mortality still. Although the survival rates have improved greatly for some cancers, others are still take a really heavy toll on the young people's lives. So the cure rates of the childhood cancer have increased to about 4/5 or 80% in recent decades. Still, large proportion of the surviving children suffer from severe long-term side effects, either after surgery, cytotoxic chemotherapy, or radiation therapies. Therefore, developing more specific therapies with less long-term side effects is of paramount importance. So right now, with the help of scientific breakthrough in genomics, we are taking the fight against the childhood cancer in a totally new level. So one of the crucial steps in this regard is the identification or actually genetic profiling of the pediatric malignancies. And thanks to technological revolution in the field of genome sequencing, it is now possible to decode entire genetic and epigenetic code of the tumor even within a few days. By that, to identify the driving genetic anomalies across the pediatric cancer types. At the same time, American Pediatric Cancer Genome Project was launched already in 2010 and demonstrated the significant difference in spectrum of childhood cancers compared to adults. So we cannot apply the adult knowledge, adult data, as the differences are very remarkable. Up to now, comprehensive molecular genetic data analysis in pediatric oncology have been rare because the patient numbers are comparatively small. However, they would be really urgently needed in order for us to further improve the survival rates of the children suffering from cancer. As our knowledge increases around the specific genome alterations in the cancer, also the treatment options can now be more personalized based on assessment of molecular alterations of identified tumor. So already a few years ago with our partners from Microtik, BMC and Australian University, we were convinced that incorporation of whole genome sequencing in a clinical practice will really enable more comprehensive and precise diagnosis, and also the access to more personalized treatments. This way, we could create opportunity to reduce those harmful medication or intervention effects, and also support easier access to clinical trials with targeted therapeutic options. That is how the Latvian Pediatric Cancer Initiative started, and the initiative which aims to collect genetic data from all pediatric cancer patients in Latvia. The goal of targeted therapies is to treat patients with a drug that targets specific genetic mutation in the tumor, regardless of where the tumor is found. This means not to treat the tumor according to it means to treat the tumor according to the type, not according to the site, because the same tumor could be found in different locations. And in contrast, the tumors in the same site may require totally different treatment approach. Therefore, the systematic interpretation of large amounts of the sequencing data, aiming to translate that molecular information or alterations into clinical indications, is very challenging, and nowadays has been addressed with the implementation of the molecular tumor boards. So the aim of these tumor boards is to identify and discuss all the potential therapeutic strategies based on the genetic data for patients who are not responding to the standard of care treatment. Therefore, the molecular tumor board recommendation comes not only from multidisciplinary discussion, including those findings from sequencing, but contains all of the different data sets which are available for specific patient. And amalgamation, putting together of these data and interpretation of these data require totally different level of skill set and also ICT infrastructure. And that is an endeavor we have committed to in the Children's Hospital. And yes, and we believe that although in many cases, genomic data application is still regarded as a scientific activity because it's not a standard of care. I think the principle that it happens in a hospital close to the patient brings us ability to kind of transfer those immediate gains back to the personalization of the care. And then finally, in a country like ours, the prerequisite for success is in the close collaboration between the different entities and among the different hospitals. And also we are looking for close partnerships and potential data collaboratives with other European pediatric cancer centers, and that's an inevitable future step. So we will keep you posted on our progress. Yeah. Thanks.
Thank you very much, Mr. Valtsābols. Definitely the Children's Hospital, as I said before, is in avant-garde of different innovations, and also you're going to be also in the panel discussion. So the questions which are addressed to you will be discussed in panel discussion at this moment. Thank you very much. And we are smoothly going to the panel discussion that we have now, health data and infrastructure. Q&A session, panel discussion, bringing at the one table different speakers already from those who were in the pitches and newcomers in the field here. So the panel participants for today: Henk Wiese, Senior International Medical Director in the Zoom; Valtsābols, Children's Clinical University Hospital, also in a digital way with us today; Baiba Vilne, Head of Bioinformatics Unit, Riga Stradiņš University, also online with us; Andrew Warrington, EMEA Healthcare Industry Senior Manager, also from Microsoft and online with us today; and Reinis Jansons, Resident Physician in Otolaryngology, Chief Medical Officer, Anatomy Next. Here he will come here on the stage because he's in a very live mode here on the stage. Please take your seat here. And of course, Emil Syndikov, Chief Technology Officer, Longenesis, is a very good moderator of panel discussion, and I'm absolutely happy to give the microphone, all credentials and mandate to start the panel discussion. The floor is yours, Emil.
Thank you so much, Martin. So, yeah, let's start with the first panel discussion. It will be related towards data. As you see during the online live stream, we have representatives from different stakeholders groups. So we'll have industrial representatives, we have startups, SMEs, we have clinicians, we have researchers and hospital managers. Some of them you have already heard beforehand. So we'll be also happy, once again, revising that we have a menti.com platform to ask questions, and I will try to address them at its best. So the topic of our conversation today will be around data. So I think it's quite an interesting concept, and you might have asked yourself, while we are live streaming this in pretty high quality, I assume, transferring bits and pieces and quite a large amounts of data, what happens with data in the healthcare institution, and why we speak about data as a challenge, first and foremost, and how we can apply this towards the patient journey, so to all of the pieces that the previous speakers and pitchers were addressing to. So with this in mind, I would like, before we move forward, I would like to give the word to each of the panelists, so they can give a first, let me name it, so slogan, addressing what is the challenge and what is the impact that data gives to their industry or to their stakeholder groups. So let me start with Hendrik Wiese. So Hendrik, we have heard your pitch today, so very interesting. The floor for the quick slogan is yours.
What you do, where you're heading for, and how you can improve the care. And that is also, if we now expand to other countries, we bring the same protocols, we bring the same database, we bring the same infrastructure, and then we have the possibility to collect the data in the same way and collaborate with each others. Currently with Saudi Arabia, with Spain and other countries also show interest with, let's say, a key clinic to have this set up and roll it out over the country. The data is really the key forward. Separate, let's say, from the medical EMR is the data which the patient collects at home, that those will be shared. Compared with the Eurocontrol, with the planes, they continuously are in contact with the planes, and we, with Cloud Care, overlooked all the incoming data of all patients every day. And where there are deviations, we try to interfere before things deteriorate, which is noted then on your upcoming consultation 3 months later, when it has further deteriorated. So we try to keep them in good shape. And then we can reduce visits and focus on an annual visit. And that is where the reducement in cost is, and also together with the benefit in healthcare. So it's also, let's say, stay connected with your patients with wearables, in our case with diabetes, with pumps and sensor data continuously. But there might be other diseases where a continuous data stream is very helpful to keep them in good shape and also reflect it to the patient back, so they can see how they perform and where they can further improve or need to contact a team. So data is really the crucial thing.
Thank you so much for addressing also the topic of different modalities of data as a sort of a bubble and engaging patients towards the conversation. We'll continue this topic during the panel, but I will give a floor to Valts. So as a hospital manager, you address the topic of personalized oncology and tumor boards, but what does it mean for you, like data-wise, disease agnostic-wise, towards the patient journey?
So first of all, I'm privileged to represent the only pediatric hospital in the country. And that means that not only the technologies and lots of data are concentrated, but almost all of the know-how in children's health stems out of our hospital. And therefore, this privilege comes also with a serious responsibility. Responsibility, in fact, about every aspect of the children's health quality in Latvia, not just activities performed directly inside the hospital. And that concerns also utilization of the data. And we should never dare to forget that the healthcare is about the patient, as Emil mentioned already before. So patient is in the center of the health system, and the data analysis should primarily serve for that purpose of the better care. So with the data, we can create more holistic view on the patients. We can personalize the treatment, we can advance the treatment, we can facilitate interaction or communication between the doctor and the patient. We can virtually improve and enhance any of the health outcomes. So, and that's what drives me to talk about the data in the healthcare.
Thank you so much. I already see good emotions, seeing that we have several pediatric care representatives on the panel as well. So very good. So Andrew, you as I would say one of the leading tech companies in the world, so as a representative of so-called, the toolkit to empower a sort of a hammer, not to break, but to build stuff. What would be your thoughts on what would be your thoughts on that?
Well, what we hear, thank you, and what we hear, I think, from our customers around the world, be they in life sciences or in healthcare or government, I think they're all painfully aware of the richness of data that they have, but they can't get the value out of it that they're looking for, either because the data aren't structured or they're siloed. But even when they are structured and siloed, you can't collaborate over them if you're concerned about privacy and compliance and these types of things. So our mission is actually to empower, and from that perspective, we build a lot of very health-focused capabilities for our customers, and we also have a number of partnerships. And just to give some examples of the kinds of capabilities that we build for our customers to then further build upon, there are things like, common health data models, data collaboration services we heard about in one of the pitches, healthcare connectors to EMR systems, APIs such as FHIR, but with built-in anonymization, health text analytics to take things like clinical notes and convert them into structured data, and even the ability, with consent, I'll say, to listen in to a verbal conversation and convert that into a structured clinical note from one of our partners, Nuance, whom we hope to acquire over the course of this year. We also work with companies like Intel that we heard from earlier to provide those kinds of sort of secure enclave computing areas that their processes are capable of within our data centers. And on top of it all, we have a kind of a framework of responsible AI. So this is sort of guidance and tool sets that allow you to do things like check for bias in an AI model and so forth. So we look at this as something where we would like to unleash the data that are there, allow our customers to unleash their data and collaborate over it, build the AI models, bring social good in a responsible way.
Thank you so much, Andrew. We will come back to this topic of infrastructure and the power of tech later on. So as we have, as Martin outlined, we have 2 languages today, so it's being translated into Latvian, and we speak English, as you might see. So we have also Baiba, and I might call her as a researcher, as a translator of the, of data insights towards new therapies, new ways how we can diagnose or treat. So what data, and rightfully, data utilized in the right manner would mean to you as a researcher? So what power it gives in your hands?
Yes, thank you for asking this. Indeed, the first part of this panel, or generally, we're talking about electronic health records and all these patient data and also biosensors. But then, of course, a big must in bioinformatics is to have all the omics data, because we need to understand the molecular underpinnings of the diseases. And I'm not just talking about genetics, which, as we heard, is actually, we're still struggling to collect those. But as a bioinformatician, you would want to have also gut microbiome, proteome, transcriptome. So whatever you can get, because especially for complex diseases like coronary artery disease, you have that genetic component and you have that lifestyle and environment component. And to have both sides of that coin, you need all these data to make your predictions.
Thank you so much, Baiba. So last but not least, Reinis, who is practicing a clinical professional as well as into digital tech. So what would be your take on utilizing data for your professional?
I think what's important is data gives us a lot of opportunity, but data also creates a lot of problems because we need to find a way how to use the data. For me, as a practicing or learning physician, what I really care is that the data that we use, the data that we gather really answers couple of problems. So first of all, it has to improve the patient outcomes, save time for doctors, and therefore reduce costs. And I'll be the boring guy. I'm not going to talk about artificial intelligence and other cool technologies. What I care is design. How do we make sure that the data that we use can be accessible for patients, for doctors, and how do we use the data to improve the communication between primary, secondary, and tertiary care? So.
Thank you. So I would like to start, with we will have several layers as a concept of onion today. So the first layer will be related to data, because we all speak, and we as putting a hat of a patient or a parent of a patient coming to the hospital, we see quite a lot of computers there, quite a lot of beeping sounds. So devices that generate, store, or transform data. But why do we speak about this as a challenge? So what happens in the hospital layer? Maybe I would give a floor to Valts once again. So maybe you can tell us from a hospital perspective. So what are the challenges in relation to data there? Is it quality? Is it not enough keyboards or disk spaces? So what is that?
Well, let me start with perception. So we used to say that the data is a new oil. So, but do we really treat the data as a new oil? Do we really treat the data as an asset? And that my answer would be not yet. So in each hospital has many people managing other assets and money, etc., etc. But data so far has been the byproduct of activities, if I may say so. We are generating a lot of data and we store a lot of data, but I would dare that only small percentage of these data are used to generate information from the data, and that's exactly what's happening in every healthcare organization. A lot of data is generated, but very little amount of that is used for making decisions. I've been thinking about this this data generation topic, and I think what we lack probably in each of the organizations in the healthcare is a position of chief data officer, who might oversee really collection, management, and storage of all of the data across the organization, and being responsible for analyzing and deriving insights from these data to support the core business of the hospital. And that's something which is currently lacking, and we are a bit hectic in generating different types of the data and not enough pragmatic how to use them. Other thing is definitely what I want to mention is that the usability of data is often linked to interoperability. And well, repeating myself, you know how the system works now, and we heard from Harris in the beginning that systems don't talk to each other at the moment, and there's very, very slow improvement in that. So achieving interoperability among the healthcare systems and seamlessly exchanging information and the data is really the prerequisite to improve that clinical operations and the outcomes. And finally, one single, possibly the most useful thing would be is to agree on that standardization, which was also mentioned before, on how the things are done. So which terminology we use, which ontologies, how do we map and record the data in the way that the values are comparable. And we talk about different types of the data. I think we are blending really the perceptions of what will be the healthcare data and what will be the, I don't know, not healthcare data. Is that more and more data can be used as a marker of the health. And well, because a patient generates a lot of data nowadays as well with different devices. So smartphones, wearables, like different sensors can help really to make better decisions. And also researchers can integrate these data into development of new innovations. And we are not there. So basically standardization and interoperability is something where we need to continue focusing.
Thank you so much. So addressing the follow-up question, let's hold in mind this chief data officer and this conversation between different skill sets within both the hospital layer and also cross-hospital layers. Hendrik, you mentioned that you do operate and do orchestrate with different data sources, wearables, maybe lifestyle data, starting from diagnostics for sure, to understand the disease and how patients should be treated. What is your take on, whether the clinical practice, may I say so, is ready to communicate healthcare through data? And we're not only speaking about, ICD code and, the blood analysis or something like that, but also adding up the bubbles such as outpatient data monitoring, wearable devices, as you mentioned before. Yes, the question for you, Enrique.
Yeah, I'm muted now, sorry. It's, let's say my first response is that what is very important that the data are collected at the source where appropriately. Let's say to respond to the previous speakers, it's the data systems in hospital are focused on financials. And currently medication and laboratory get more standardized. But how the physician and nurses and dietitians collect our data is not so much standardized. It's very much in free text. And it's really where we try to stratify it in different field items connected to, let's say, how do we want to create our dashboards? And there the physicians only have to enter the data once, and then it works in the dashboards and their reminders and the quality control, etc. That is really helpful. So the focus should move to, let's say, the care providers to really collect, let's say, and have the physicians organizations deal with what is the kind of data standards for the eye physicians, for ear, nose, throat physicians, for pediatrics, and that is, I think, a very important thing to collect those data. I lost a bit. Let's say, can you help me on the other part of the question?
No, that's totally right. You addressed this. So basically, the question was how we can transform this and translate this to the clinical practice. So maybe quickly switching to also Andrew. So as a representative for tech, you mentioned we have seen previous speakers today speaking about federated learning pipelines, AI, segmentation of data, and basically generating value out of that. So what for you as a infrastructure or ecosystem enabler would mean qualitative data? So how to build this bridge between the hospital, as Valts outlined, the one-of-a-kind state-wise hospital holding and basically sitting on the vast amount of data, how we can transform this into value. And quickly squeezing in the question from Menti is the same thing as I mentioned before. So we're streaming the video online now, and which means that we download or upload very large sizes of data, and we speak about AI of segmentation, different parts of that. So what is the issue of transferring the data? So the internet is there, so what is the issue, in your opinion?
All right, maybe I'll start with the first part, and I'd really like to just comment on what Henrik said. I think let's talk about the healthcare professionals, and we're talking about making the data sort of available here, right? And let's look at what I understand to be the day-to-day life of an HCP versus potentially also a researcher. But the day-to-day life of an HCP is switching constantly from one condition to another. Maybe all in oncology, maybe all in a specific branch of oncology, but each patient is very different. So they're switching contexts frequently and with very short amount of time. And they're collecting, yes, data in free text. And I think that creating an experience where they have to also comply to filling in specific fields in specific ways so that the data are pre-structured is probably a pretty heavy burden on somebody who just wants to help their patient to get better. So I think that one of the things that we need to do and for which we build tools is how can we convert that seamlessly from the free text of what a doctor is typing in, or the free speech, the conversation going on between the doctor and the patient, into actual structured data, even coded data, diagnoses or potential diagnoses, medications, things that can therefore afterwards all be kind of recorded and then just confirmed by the doctor. And those, I really think we need to make that seamless from the beginning so that the doctor can be looking in the eyes of the patient, having a conversation, and not looking at their screen, listening to the patient answer questions. That is part one to get you to structured data that you can actually use. I think the broader question about how can we collaborate over data is a little bit more about implementing standards, choosing standards and implementing them. A great standard that probably a lot of us have heard of is the FHIR standard, right? The standard around HL7 for transfer of data and APIs. If we can implement these kinds of standards, I think we would be in more of a position to interoperate data between systems. I'm trying to think, maybe help me out as well and elaborate the question further. Is there more I should say?
No, I think that's exactly what we needed to put there. And let's once again mark, for the organizers and for the listeners, that standardization is the key there. So am I right? So this is and
including common data models as well. Like there are a number of different areas we can standardize in order to make the exchange of data simpler. And with regards to, there was the transferring of the data question. Let me just say that transferring one medical image is not a big deal. Transferring 500 is probably not a big deal. Transferring, 10,000 medical images, right? It gets to be very, very high volume, and it gets to be inefficient to be storing those in multiple places. So I think there you need a combination of how much analysis can I do on the edge where the image is taken? Can I do segmentation and pull out just that text file of the segmentation data? Is that all that's relevant to send over the wire? Or do I need to send the entire 3D medical image across? I think it's just a question of optimization and not generating more cost is really where the question is. It's not so much a bandwidth one anymore.
That's very good to hear. So, and I hope that we don't have any latency here, so it means that the through output is quite good. So once again, the standardization and actually collaboration on local layer slash global or ecosystem layer is needed. So we started speaking, let's finish with this, data generation place, and one of the quite straightforward scenarios is a clinical practice. So, and this symphony of data generation is being made by conversation between patient and healthcare practitioner. So, Rain, is from your perspective, from a healthcare practitioner perspective, so why do we still address data question as a challenge? So you have a tablet, you have computers, so why do we do that still?
I think it again comes, it has a lot to do with standardization. And I'll just give a brief example. And I think the standardization not only as a technology thing, but also a standardization like as a state-wise. Let's say I'm currently actually in Pediatric hospital where we have the healthcare information system that works very well inside the hospital, but then we're having patient appointments, and you have a patient that comes from some doctor, I don't know, somewhere outside of Riga, and they come with this little label with something written in hand, and you're just trying to figure out what has happened with the patient previously. So this is really, again, about the standardization. How do we make sure that everywhere in the country we have one standard of where the data is stored, and how do we communicate the data between different institutions? And unless that happens, I think it will be very, very hard to even do anything else with the data, because it's just, there's so many parts of the patient journey that are missing. Patient comes, we see them, we see what happens with them with the hospital, we treat them, we make recommendations, but what has happened with the patient before he came to the hospital, and what happens with the patient after he's discharged, that's where the problem for physicians really is.
Okay, thanks a lot for addressing this. So once again, we came up to the same conclusion. It's very good that we have consensus here. And switching to Baiba, and actually switching to another part, which will be, more of a value layer or translation layer. Baiba, as a scientist, so we have many institutions, we have seen many researchers today here. So what is the challenge for you, first and foremost, to create new drugs and therapies? Very, very global question. So why there is still a challenge through data that, we don't have super-powered algorithms to help us within one click? And the second of all, is the healthcare, a little bit provocative, is the healthcare ready to utilize the insights of your research, like also data points, and translate this into the patient care, into the patient journey?
Okay, thanks for this very complex and multi-layered question. I will try to answer this in three parts, I would say then. So the first question is, why don't we have drugs and treatments already? So this question, I think, was partly addressed by previous speakers. It starts already with the medical clinical data, which is not standardized. Then, of course, there is a lack of data still. As I already pointed out, even if we would have the standardized medical data, we lack molecular data, which is not being collected in routine usually. And then even if we would have that data, I have to say that lack of standardization is also a problem of bioinformatics, because there are so many open source tools out there, which is great because it creates new opportunities. But it also creates new challenges, as you need kind of a benchmarking and find those best practices, which is also currently just starting to emerge. And then afterwards, of course, even if you develop these models, there are a lot of questions on that. So we don't know the ground truths. So it's hard to do any validations of these models. And then, of course, also these models are known to operate these need to be tailored to a particular country and particular situation. It has been shown that the model predictions can differ, of course, depending on the input data. And even if it's being standardized, I guess we will have that some level of noise is always there, and we have to learn to cope with that noise and work on better algorithms which can incorporate that. And yes, of course, it's a complex question, because we have these factors which I mentioned, and maybe many more factors we even don't know because we're not there yet. So I think in every step moving forward, we will detect new problems. As for example, now due to GDPR rules, we have this model explanation. We need to be able to explain also our predictions, which we make, which is maybe not also always easy. So new problems are emerging as we move on, I would say.
Thank you very much for elaborating. That's I still hope that, future-wise we'll have more of a science translation science towards the patient practice. Coming back to Hendrik and actually, going to the topic of value and translation of data towards value. In a nutshell, what you mentioned in your pitch is basically you gather different classes of data to help healthcare practitioners and patients to bring higher quality of life and also better, more personalized treatment. So the question is, it sounds great. So the question is, have you seen what was your approach towards actually showing that, hey, if you look at this data and invest in that, in the end of the day, you will have better results. So it's not maybe crystal clear at the first sight, but there is a great potential.
This really was a long journey. And it started with me programming myself the database systems. It's hard work for evenings and weekends to do it alongside your job. But it is also very rewarding. And here we try to translate what you need to have. And the very important factor is if you collect, also as a physician, you want to have a feedback on your dashboard. And if you have feedback on your dashboard and the dashboard doesn't work because you have lacked, you have forgotten something, or there is missing data, then you're motivated to feed it in. And I'm not necessarily, let's say, completely convinced about, let's say, doing analysis on free text notes, because can you use that for scientific purposes? Probably not. And so we try to structure it at the front just once. And then use that data, this chronic care, and use that data over time. And feed it in also as a reflection to patients. Your patients can update or flag it to the physician and a nurse to improve it. So if you have this structure right, and then you have your dashboards, and also the patients can challenge you. Why is this flag on orange and not on green? Or why is this curve not getting to better to green, but moving to orange? Then you have a more equal discussion between the patient and the clinics. So this was radically a journey. When I started collecting data from the blood sugar meters and the sensors, at the time they were not yet available 10 years ago, we had them on the screen, and the patient liked to see this color-coded. They could see, now I understand. Now I know where to change my insulin. And then I thought, well, I could present it back to the patients in an app or in an email, and I built that. And that went viral. The patient loved it. And it generated more improvement in their outcome in HbA1c than the introduction of an insulin pump. So transparency of data and dashboards for clinicians is a great help to improve the care. And when you do that then in a kind of Olympic game that you all share the same game in the same spot, and you share the databases across the different premises, across the Netherlands and also abroad, then you really can see what does work and what doesn't work. It's the same style as you have in Hamburg, in the Martini clinics, where the surgeons share the same coffee room and they're going to talk about complications. And, oh, I have to look with you. I come on with your operating and tell me your trick, why you have less complications. And so they have a kind of attitude to improve themselves. And this is difficult, mostly difficult in a general hospital where they reach out to all kinds of topics. In healthcare, it's very difficult. And here you see the clinic in the University Hospital of Volts, where you really focus on the disease, you collect all patients of the country, and then you really can do a better job and improve. So focused care is also a way to do it. Focused care will help you to build the database because there is a trade-off to do it. And so I would really refocus on what the clinicians and the nurses do in collecting the data and try to build a system which motivates them to use it to the full extent because they get something back. If you don't get something back only from your managers, that doesn't help. you must have in your professional area. That is what be my advice.
Thank you very much. Let's hold this in in front of us as well, bringing the value to the stakeholder, exact value to the stakeholders. I really love your example about the patients as well, and maybe also a question to Andrew. So we've heard from Bye and also from Hendrik that we should translate data into value, and you've mentioned also in our conversation before the summit the use case where you actually take the vast amount of socioeconomic, epidemiological data, also diagnostics data. So is it possible for us to transform and translate value from such vast amount of also noisy sometimes data? And just a quick pinch of salt there, can we from this microscopic value, can we transform the value to the individual layer from such approach?
Yes and yes. Maybe just to give a bit of a background on that, the question we were tackling is cardiovascular health, and the question that we had was, what are not just the health determinants of cardiovascular health, such as is somebody obese or do they have high cholesterol? But what are the social determinants of their health? Like, are they sedentary? Do they have the opportunity and do they exercise? Do they have access to good food? And these kinds of things. And so what we found we were able to do there, right, or what our goal was not just to kind of pop up some kind of a risk calculator, but to ask ourselves the question, can I, as a health planner, look at AI models that have been generated from an analysis of broad data sets to work out, hey, in my community, it seems the problem is smoking. Smoking is, what I mean by it seems the problem is, there are also problems with obesity and maybe with cholesterol and access to healthcare. But it seems like the one that I could tackle, which would have the greatest value in improving cardiovascular health in my community, which could be as small as a postal code, is an anti-smoking campaign. If I can get smoking down by 2% in my community, then I can, reduce hospital cardiovascular events by X. That was our question. And could we do it? Yeah. Could we do it really, really well? Not yet. And the reason is, what we went after aggregate data across an entire continent, practically an entire continent, but no, it was a large country over in North America, so you can pick one of the three. And we found that we could find the correlations, absolutely. But what we couldn't do, we knew in every sub-geography, hey, there is this rate of smoking, obesity, these are the social determinants of health, et cetera. But we didn't know which individuals had which. So the model was predictive, right? But I wouldn't yet use it in the real world. And what it was missing was the link. So if I say, in this community, there's a high likelihood, or there's a high correlation, between smoking and cholesterol or rather, no, I'll put it a different way. In this community, I have 20% are smokers, 20% have high cholesterol, 20% have obesity, and 40% have cardiovascular events. There's a complete possibility that actually it's the people who are not smokers, don't have obesity, and don't have a cholesterol problem who are having the cardiovascular events, because they're not linked on an individual level to say this person who was obese and did not smoke and had fine cholesterol had a heart attack, and this other, who was healthy did not. So I think what happens is you can find those correlations and you can get predictive, but when it comes down to making decisions, you need your data to be at a high resolution and linked together in such a way that you can understand the individual cases, or your model that you're building, training, can learn what the individual cases are to be better and more predictive as to what is the best intervention you can make in that community. So the answer is yes, we can get some understanding of how these pieces are interacting with each other, and then getting really good at it. We need higher resolution data. I'm not saying we need to know the names of the people. I think, but we do need to know which combinations of factors apply to a individual.
Thank you, Andrew. So basically what you're referring to, so we have a set of formulas and the components there are the types of data. So they're also referring to the question coming from Menti about what data we need to actually translate this into the value. So it should be based on a certain disease. So the formula of the recipe of components.
Oh, and it depends. Are you looking to solve a public health issue, or are you looking to solve the problem, the day-to-day problems of one person? So I am a type 1 diabetic. So I agree with everything that Henrik has said. It's you know, I don't need to know social determinants of anything. I need to know my glucose curve, right? My glucose data minute by minute. So I completely agree with him. So it depends exactly on which decision are you trying to make. We'll tell you which constellation of data you need to bring together.
Sure, we will also come back to this recipe question addressing to Baiba, but beforehand, also another question, since we have tech expert here, Andrew. So we speak about the standardization of data. So once we have the set of dictionaries or the standard, the prospective data will be stored in the right manner. But the question is the following. So in our country, and not only in our country, in various countries, a lot of retrospective data is stored as a wet ink, so-called, or a paper-based format. And how not to lose this data? Is there any mechanism how we can translate and plug it in some of the tech solutions to use this?
Yes, the tech already exists even for handwritten, though you'd want to test it. I think, but definitely, I just want to maybe go back into a little bit sort of what we're really looking to do is to switch all that sort of analog, unstructured material into structured data. And so so I can talk about Microsoft's approach, but I'm sure there are plenty, right? And our approach is, we have a series of cognitive services that you can link together. And one of them is handwriting recognition. So let's first convert that from handwriting, if you will, into OCR, into an actual text. And then afterwards, you're dealing with the fact that it's unstructured text, right? It's prosaic, it's not. And so I alluded earlier on to our text analytics for health with FHIR conversion. And let me be a little bit clearer about what that is and what it does. The text analytics for health have been trained on medical ontologies, and what they really can do is pull out of a text. I recognize in this text that these concepts are linked together in this sentence or across multiple sentences, right? And they are a diagnosis. They are that it's a probable diagnosis, or that it's not this diagnosis, a negative diagnosis. So they're dealing with negation, they're dealing with qualifiers like probable, and there's diagnoses, there are, they're pulling out medications. This is a prescription, this is an amount, this is a symptom. This is a symptom that the doctor has written was reported by the patient. This is a sign that the doctor reported, right? Pull all that out and structure it. And then even, yes, put it into these FHIR API resources that, as I was alluding to earlier, get actually linked up and coded, like with SNOMED codes or ICD-10 codes. So the idea there is, I could imagine a two-step process of converting from handwriting to text, and then converting from unstructured text to structured FHIR resources. And you're probably thinking, well, that probably won't be 100% reliable, and I would tend to agree with you. Anything that we do with AI has a confidence level linked to it, right? But the question is, I think that you can, as you go about it, first be doing quality control, doing a bit of retraining, making it as great as it can be. And then you would need to flag any data set where you weren't entirely sure, as saying, hey, this was generated out of these cognitive services. We expect it's 98% accurate. And that way you can have a confidence level on the data set, and you don't use it inappropriately for, as established fact, but rather for potentially wider research purposes. So I feel like I hope I didn't say too much or too little, but yes, the technology is there. Let's use it carefully and responsibly.
That's totally perfect answer, I think. And also, we have had one of the presentations today, one of the keynotes referred to the term augmented intelligence, not artificial. So working hand in hand with clinical practitioner, as whether checking up whether the handwritten text to digitized works perfectly or not. But both of the previous panelists mentioned the patient, the translating value to patients, and Waltz. Both on your background you have 2 patients on Rainbow, and also in your scheme you have the center as a patient and a value towards that. So, and pediatrics especially being a sensitive domain, because we're speaking about children health. So have you heard or defined any questions or demands coming from both patients and also patient parents towards bringing value from data? And what are these?
Okay, well, I think it's very clear, and many things already have been touched. I see the 4 biggest blocks which explicitly or implicitly come as a demand from the patient. So one was we touched upon already, was a precision medicine. So we're treating the specific individual. We're not treating the disease in general, we're treating specific individual. So precision medicine is one block which is a demand. The other is, what Reines already mentioned, is an integrated care pathway. So linking every aspect, every bit of the care journey happening like long before the hospital, linking it to the hospital and post-hospital, and also potentially including the remote care opportunities. So everything as an integrated journey. So the third one is probably very much linked to what was mentioned regarding the diabetes. So technology-supported self-management. Clearly, that's also a demand. Patients are engaged in their care through different remote self-monitoring, either also the personalized care planning, health education, diagnostic aids, treatment tracking, probably alerts or reminder tools, and these being linked also to social networks. All of those activities contribute to the full picture. And clearly, well, this is something which comes as a request from the patients, how to integrate all of this self-management into the common care plan. And then finally, as a hospital manager, so we are talking about the data-driven hospital, the data-driven informed decisions. And not only we are using the business intelligence systems to guide us on more sophisticated resource management decisions, but also the things which directly refer back to the patients, like managing demand, access, patient experience, etc. So the patient really is at the core of everything, how the health system will change with the help of the data. So currently, if I may say, we are still operating in a old model of let's say participative, patient-centric system where patient is at the center, but we are not fully engaging into decisions. And the current system is reactive, so we mostly treat already the conditions which will happen and protocolize. So we're talking about the guidelines, evidence-based, etc., and these are protocol-based. Now the future health system is different, and it's predictive, preventive, personalized, and collaborative. And each of those aspects requires really input from the patient and a commitment from the patient. If we talk about the predictive, so that's a choice. So that's a patient choice, how much he wants to know about his risks, etc. The same goes to prevention. So what's his readiness and readiness to engage in some preventative activities and to comply with them. Personalization. So how much of the patient is ready to reveal out of his data, which could help us to make the most personalized decision. And finally, collaborative system. So making the patient or his family as part of the decision making based on the huge information set which we might have on our hands. So, and these decisions are not always straightforward. This might be sometimes a very tough decisions, either to choose this or that, to prevent some long-term risk or not. And so therefore, I think the demand is already here, and that demand will be just increasing in time. Yeah.
Sure. So transferring the question to also all of you, but starting with Reinis as a clinical practitioner. So we've heard about variety of tools, and I think if we guys open such a platform like Azure, we can spend years in investigating and experiencing all of the modules there, how we can work with data, transform it, and generate maybe new insights and data points. So the question to all of you, but let's start with Reinis, is how not to get lost in this vast amount of opportunities and vast amount of data there. So what should be the so-called MVP for the clinical practitioner? Should you have a, I don't know, like red light, green light, orange light type of scheme, or, you know, how do you envision that? So not to be, you know, like as a data scientist with 50 displays in front of you.
I think, first of all, to make a clear objective, we must ask ourselves a question: what do we want to achieve? And only then start building these solutions for one specific problem, because oftentimes what we see is now we have people, it's a multidisciplinary task to create something for patients. It has to involve doctors, has to involve tech people, and sometimes, you know, tech people have one way that they see the life, and they want to achieve something by using the technologies that they have created. And then the question is, how do I say this? How do we make sure that really everything that we do is really answers some specific question, whether it's feedback or whether this reduces costs for the hospital? So there's a big push always from technology side that, okay, doctor, take this, take that, and you have to use. But now I think we have to think about the user experience on a daily basis and ask ourselves a question: what really happens on the on daily basis with the patient and doctor communication? And I really liked one thing that Walt said about the patient feedback, and from being the healthcare system being reactive to being proactive. And I think I really like this example, because when patient comes, doctor prescribes him a treatment, and then they say, okay, I'll see you in 1 month, for example. And then the doctor doesn't know anything about the next time he sees the patient, and we do not have this way to figure out what happens. We do not have a system to collect this feedback from the patient. So how do we engage the patients to answer to these questions, to have a way for patients to communicate with doctor without having to go to the hospital? Because otherwise it again comes back to the hospital. If patients are not communicating with their own doctors, what happens is at one point patients really their disease, for example, deteriorates, and they go back to the emergency care hospital or emergency care clinic, and that again is a burden for the hospital. So I really think like creating this feedback, I think we don't even need to look that much about this, how do we collect and store this data afterwards, just one tiny problem. How do we make sure that patient can tell to his doctor that something's not fine or something's better than it was before? So, yeah.
Sure. So going back to Andrew, so do we have such tech that, you know, such integration will be unobtrusive and robust for the healthcare practitioner? You know, not sitting on the set of dashboards, but actually having this value, as Reinis outlined, how to heal the patient in very broad terms.
Yeah, yes. You know, as a tech person in the tech world, I can think of 3 different ways to answer that from a technical point of view. What's really interesting in this particular topic is, what will the patient choose to do, and how will they choose to interact, and when would they be comfortable interacting, and when would they what would be their incentive? And so I guess what I mean is, it's hard to communicate with the doctor could be. Do I need to phone them? Will I have to go through, multiple layers of phone before I can get to the doctor? Do I send an email? Do I get feedback when I give feedback? Does it come? These are kinds of the things that potentially patients, at least I as a patient, have thought about, right? So I think whatever it is, needs to be something where that interaction benefits the patient and the doctor equally. So I feel like it's a very, very complex topic. I mean, I know of cases where this has been done successfully. We know, for example, at HUS in Finland, they have the health village, and you can go to healthvillage.fi and see the entering page. But that is sort of an ecosystem that connects up the hospitals to the patients through a place where the patients feel relatively at home. All of their data is there in a way that they can understand it, as well as guidelines in terms of pathways that are tailored to them individually. And so they naturally feel comfortable there and they go there. And if they have a problem, they would feel like going there to talk about it. So I feel that I kind of want to agree. This is more of a how do you create that psychological impulse or to go and have the conversation from the patient side. It's easy when you have a sensor. I have a sensor, it just sends data to my hospital. That's press a button, it's done, never have to think about it again. But what about other disease areas where there aren't sensors?
Sure, and Hendrik addressed that your use case brought higher patient satisfaction, also engagement rates. Maybe you can...
Yeah, absolutely.
Yeah, maybe also passing floor to Hendrik. Maybe you can explain us. So, what was this golden formula? How you got patients amazed, engaged, and turned in this emotional part of conversation, generating data through that.
Yeah. I think the focus and motivation of the team and us trying to achieve that. That was a key factor, and especially also the data and the database. Normally, the hospitalization rate in type 1 diabetes care, it differs among countries, but you will not be surprised if the hospitalization rate is 10, 20, 30, 40% different, depending on the country. Our hospitalization rate, by a proactive management and responding on hypoglycemia and trends or gradual deterioration and interfere before things go wrong, our hospitalization rate is less than 1%. Mostly occurring only in the newly diagnosed. Most newly diagnosed, there is no hospitalization needed. We do it all in outpatient care in our locations. And we train the people and they go through a structured learning curve, respecting the needs of the individual family and the individual patients. So we have different pathways, intense and or less intense, where they have occurred learning habits. Hospitalization rate of less than 1% is a big achievement from a cost perspective, but also for the families. They continue their education at school, they continue their sports actions without deteriorations, and that is, and then it comes from two sides. Let's say patients are satisfied, they talk to other patients come up with a high demands and expectations, so we have to respond to that. So we are all in the same game, if trying to improve and do every year better and satisfy gradually more and more patients. That is the key thing. Secondary is, let's say, the payment structure to improve that and have enough high cost available for the sensor and pump technology, which really bring it back to normal life. Currently, with the application of the latest technology, we have the patients in almost biological normal ranges of their glucose patterns, almost normal, completely normal. And that is really new in the last 2-3 years that we get there, and it's exciting. So we say our target is a life with a normal life expectancy and without complications of your type 1 disease. That is the target we try to live up. And that is the challenge which patients try to take, and their families, especially in the young ones, the parents. normally they would go from pediatric to adult care, but they come back. And we now have internists employed in our different centers so they can continue the care. And also other internists in the country refer their patients to us if it got more, let's say, technology involvement. They don't have that hospital which can deal with all these data. They don't have that surrounding and the patient demand for it. So that is really, let's say, it's a gradual journey, step by step, that you move to another area. And we as a focus center can quickly adapt to it. We can adapt our databases. We can adapt new devices coming to market to integrate it in our system. We only have that focus to do so. And there is no competition for us with cardiology or with surgery, etc. It's one focus, one clinic concept.
Thank you so much. So we've touched upon this patient voice, or enabling patients, or bringing value to patients. So the question to Baiba, so you work with a new insight generation. So basically we will be treated with something you're probably researching in the next years. So what is your point of view there? So how you translate your insights into the, empowering the patient voice? So is there any digitized or analog bridge already built, or do we still need to hire some architects to do that?
Yes, thanks for the question. Again, I don't think it's a technological question, because let's take that coronary artery disease as an example again. So since 14 years now, so since 2007, genome-wide association studies have identified like over 200 significant genetic variations associated with the risk of coronary artery disease. But in clinics, we still widely use scores like Framingham risk score, which only consider the classical risk factors like smoking, diabetes, family history. So, and now it's an intense debate whether we should include those genetic scores into these predictions. So it takes 15 years after science already has established it for clinics to start the discussion. So I think it's maybe not a technological question, it's more like a question of, policy making and all these other restrictions in that way. So yeah, that would be my answer.
Thank you so much. So coming back to this, human factor and communication between stakeholders. Also a question to Waltz as a hospital manager and the lead. So how do you see, so basically you mentioned the tumor board. We've heard and seen the prime example of your internal EHR solution, also BI solutions. How should we move forward? How can we translate this from one hospital layer towards orchestrating among other university hospitals or private or polyclinics, etc.? So who should be the mediator, and what should be the acceleration point there, in your opinion?
Well, it's a tough question. So we, as a hospital, have always been ready to pilot the things. So and ready really to share like pros and cons of our approaches, etc. So, and I believe honestly that our experience can be transferred to some other like national applications as well. So the business logic of our internal hospital information system, I think it's very, very strong, and clearly with additional like technical advancements, it can also be transferred as a business logic to the other hospitals. So that's an opportunity rather than starting from scratch. So that's one of the opportunities. So. Other than that, I think I subscribe to what was said by the minister, that there is a role of the state in setting the standards and setting like some of the key principles, key architecture. But other than that, so I believe that the future system should develop in a like modular mode. Yeah, like if you imagine the grapes attached to this central cone. So basically that each separate module can be developed either in-house or with a partnership of external vendors and or startups, etc. So the key is really the integration and interoperability. So and the same standards, the same principles. So one module could be replaced if it's outdated or replaced by the better one, etc., etc. So I don't think that there's one system from one hospital or from the state which could serve all of the purpose. I think that the principles, the business principles could be taken, the standards, and like integration principles. That's how I see it.
Thank you. Just before moving to the summary part, quick question from the Menti platform. Valts, to you once again. So you mentioned about the tumor board, and there was a question, most probably from another hospital as well. Would you, once piloting this project, would you also translate this to other players? And will be the possibility to learn from your pilot by other hospitals? And a quick addition to that is whether the hospital is ready to become a certain pilot sandbox. You said that the hospital should also pilot and validate. Are we ready for that?
No, I think I will start with the second question. I think we like vocalized our readiness already like several times, and not only vocalized, we've been engaged really in quite interesting projects already since previous meeting which happened like last November. So we are engaged in an EIT Health initiative to develop the solution for a digital community space for patient families with chronic diseases or rare diseases. So that's in progress, and we are cooperating with the startups to build that solution. So in that sense, what I want to say is that we are already some kind of the sandbox. And another thing is that we are looking forward to convert our electronic data. So we have a full electronic data in a hospital. We're going to convert it in a digital research environment, allowing really to use that data for a different purpose, not only for primary care purpose, but also for a secondary use of data for research, for innovation, etc. So because that is a way how we can transfer the value immediately back to the patients. And answering the first question, clearly, well, we are happy to transfer the experience we will have, either being a tumor board or any other like ecosystem approach which we are building here. As I said in my initial statement, that we feel that responsibility of connecting everything what happened in children's health. And I do believe the same principle is in many areas. So all of the oncology should be connected somehow. The cardiology should be connected somehow. Only then, if we look at from the ecosystem approach, then we can achieve the results, not like working in the silos.
Thank you so much. So taking respect to the time of the panel, let's switch to the so-called summary section, a call to action. So in front of us, watching online, we have policymakers, clinical practitioners, all of the stakeholders there. So from your experience, what will be your lesson learned transformed to sort of a call to action or things we should consider or be looking at starting it's Friday, starting from Monday as an example. So Andrew, may we start with you. So what would be your take on that?
What we should be looking at starting from Monday. Pass. I'm coming back. Come back to me, please. Give me 2 minutes to think that one through.
Sure. Not a problem at all. So let's start then with let's pass to the clinical practitioner. Very briefly, what would be your take and call to action for everyone of us?
Well, my first call of action would probably be, let's start from the very simple things. Let's try to figure out things that we can do simply. Start with questionnaires, something like that, and then only then let's go to the complex things to do. Another thing that would be more targeted to the state, to the decision makers in state level. Let's not try to reinvent the wheel. Let's just focus on figuring out what's needed, what's the standard, how that it works, and I think we should let more external vendors take care of the end result. If we just make the policy standards, what is the patient safety, data safety standards, and etc., and then just let's give external vendors who have the great experience in developing technologies, let them do the work. Not all of it, of course, but at least some of it. And third thing, this is just one thing, please, everyone who works in healthcare, starting from Monday, let's think more about the design, because everything in healthcare is ugly, design-wise. So let's just think about it. Let's not forget about it. If in order for patients to feel satisfied or feel engaged, it has to look appealing as well.
Perfect call to action. So, Hendrik, what will be your slogan for us? Starting today, let's be agile. Let's not work waterfall-wise. Sure.
Reshape healthcare from dealing with disease in moving to keeping everyone healthy, and moving from hospital centralized care to principal remote care, and only do visits when it is really needed for special assessments. For that, you need a kind of data platform, but you also need experience. In the Netherlands, we have 80, 90 hospitals, which take care, every hospital, for everything. Only transplants and oncology are centralized, let's say, roughly, but every hospital has the complete responsibility, and given the travel distances, it's not necessary. We need to focus, and we need to reshape also, let's say, if you move to healthcare, the error might be that you pay investment to do remote care, but you don't free up the money, the resources, which is linked to the inpatient care. So you should kind of move to a kind of flexible system so that the payment structure has more traction on remote care than on classical in-hospital care, and more on centralized care focused on better outcome than on general care everywhere. So reshaping healthcare, but it really depends on the focus. Is it one time off surgery, or is it chronic care where you can bundle the chronic care together in a kind of chronic care centers where you have rheumatoid fever, chronic lung disease, diabetes care, which all share a kind same of different attitude. So reshape healthcare from something which is localized in your city to something more wider, regional, because it is possible to fill that gap with remote care. So reshaping healthcare.
Thank you very much. Thank you. Let's still just 2 minutes from our main moderator and finish with a very quick, direct slogan from our other speakers. So passing the word to Baiba.
So yeah, I would say let's start right away and let's reshape our thinking, because currently it's still like there is an elephant and we're still seeing each different parts of it. But we also have to learn not only to zoom in, but also to zoom out and remember that it's a complex system. And I'm, as a scientist, I also have to know and try to influence what policymakers are doing and vice versa. So this would be my take-home message.
Great take-home message. So, Valts, any slogan from you?
Well, I can subscribe to what was being said, but I would add one thing which we need to start doing already now is really to build the trust in the public, among the patients and everyone, to be ready to share the data and to share the data for the common benefit, for their own benefit, etc. So otherwise, we can build all of those systems around, but if the people will not be ready to share the data because of the lack of the trust, I think that will be like a significant bottleneck.
Great, just great. Andrew, as a technology enabler,
Thanks.
yes.
I have two thoughts then. I think one of them on the ground, firstly, I just want to agree with Valtsa. So back in the day, 2 years ago, we were looking at sort of blockchain things where people would have complete control over the data and how it's used, and that breeds trust. Transparency breeds trust. So imagine something for the patient where they feel 100% in control. I have a second and a third. The second one is do something today or on Monday. Phone somebody who's got a data set that you didn't think you would be able to convince them to give you access to, and have the conversation and try to do something and see what's blocking you. And the last one is to the minister. Let's start working on the standards, because if you can pull together the community, the healthcare community in Latvia, to have that conversation around the standards and to decide who should be deciding the standards even. That's the first step. That's the first step. So that is something for the long term. Okay.
Thank you very much. I think it was a great and a crystal clear call to action there. So before moving to Martin, I would like to thank you all, dear panelists, for this excessive and very deep, interesting discussion. So we wish you a perfect day, and I hope to see you later to continue our discussion, working together hand in hand towards bringing healthcare to the new level. Thank you so much.